So now we want to talk about spinal monitoring. And the objective of this section is to review methods used, including anatomy and vasculature, the neurophysiological tools, and the effects of anesthesia. So those are the four things we're going to cover. We probably will skip over the anatomy fairly quickly and spend more time on a little more time on the vascular part of the anatomy, and then on the neurophysiological tools, and then a few comments on the effects of anesthesia, and then we've got a section on cases with spinal cord monitoring, so you can see what the data look like. So we're all familiar with the anatomy of the vertebral column, and I don't want to spend a lot of time on that. I think, just maybe a word back from my perspective. I think one of the most complex things we're involved with is surgeries of the spinal column. I think the spinal column is just an incredibly complex system, and it's a lot harder at times to visualize what's going on in the spinal column than it is to visualize what's going on in the brain. So I think from a perspective of thinking about the data, the spinal column is incredibly complicated. So it's important to go through this stuff, have an understanding of the vertebral anatomy, and appreciate the differences between the different vertebral body sizes and the discs and range of motion issues. We don't worry when you're doing monitoring. You're not worrying about, is the patient going to come back to you in 3 months and say, I'm not happy, I still have pain, or whatever the issues are. But we are worried about how it all fits together in the operating. Again, I'm not going to spend a lot of time on this. The vertebral structures. I do want to say something here about myelopathy. Myelopathy is damage to the cord, probably caused by decreased blood flow, secondary to these bone changes in this vertebral column. I can't emphasize enough, some of the conversations we've had, is that when you monitor patients that are myelopathic, you've got to work with your anesthesia colleagues to make sure that the pressure stays elevated. And elevated, I mean mean arterial pressure in the 80 to 85 torr area. Because if the pressure were to drop in a myelopathic area low enough, you will expand the myelopathy, and that can happen very rapidly. So if you have a pressure drop that lasts for a minute or a minute and a half, you may expand the myelopathy independently of whatever the surgeon is doing. So you want to try to eliminate that. So if you know the patient's myelopathic, discuss it with the surgeon, discuss it with anesthesia, and our recommendation always is 85 torr. But some surgeons don't like it that high for the mean pressure. But be aware of that. Don't let it, because it's one of the things you can prevent before you even start doing anything. Again, more vertebral information, which everybody's got at their handy site. I want to spend a little bit of time on the anatomy of the spinal cord because it's kind of important to have this organization in your mind. First of all, the spinal cord's probably got a diameter like a pencil. So it's not exactly the world's biggest highway. And there's a lot of things that run through that pencil. The things that we can monitor are the things that in the dorsal columns, okay, nucleus cuneatus and nucleus gracilis cuneatus, and the things that are in the lateral corticospinal tract. And that's where the information that we get comes from. All of these areas back in this region. They're all somatopically organized in ways that are important. If you think of the dorsal columns, the more caudal you are, the more there's information here. These parts don't exist. And so as you go rostral, then these columns fill in. Okay, so there's an organization there that you've got to be aware of and use to your advantage. Same with the corticospinal tracts. They are organized somatopically in the sense that as you go more distal in the spinal cord, the corticospinal tracts become smaller because there's fewer descending nerve fibers. So we have this picture of what these things look like, but the picture is not accurate. It's actually modulated by where you are in the rostrocaudal progression through the spinal cord. So it is important to keep that in mind when you try to think about what you can do with sensory potentials and what you can do with motor potentials, and what you can do with, say, D waves or things of that type. It's also important to have this in mind, and we'll talk about the vasculature. When you think about the vasculature, so the dorsal columns get their vasculature supply from, this kind of represents the vasculature supply for the entire cord, and you can see the segmental arteries coming in off the aorta. But how they distribute in the cord is extremely important. And this is key to understanding a lot of the changes. So the dorsal columns get their vasculature supply from the posterior arteries. So they're fed entirely posteriorly. The corticospinal tract, which is up in this region, gets vasculatures from the anterior spinal artery, so it gets some coming in this way, and it also gets some from the posterior spinal artery, so it gets some flowing down this way. So depending on the level in the spinal cord, the corticospinal tracts may be getting as much as 40 to 50% of their arterial supply from the posterior arteries, as opposed to getting 100% from the anterior arteries. So there's a gradation of how the arterial supply to the corticospinal tracts works out. And it's kind of important to have that idea in your mind when you think about changes in both somatosensory responses and in motor potential responses, because that, if you can think through that kind of arterial distributions, a lot of times it will explain a lot of things that you see that appear to be discrepancies or even consistencies that you're not expecting. The other point I want to make about the spinal cord, I've become, there's something we don't know about the spinal cord, okay? We don't know, we talked about the amount of blood perfusing the brain, 50 milliliters per 100 grams per minute. We don't know what that number is for the spinal cord. I've searched and searched and have been unable to find a published number for perfusion in the spinal cord. And it's a pretty good guess that it's different than what it is in the brain, just because of the architecture of the cord as opposed to the architecture of the brain. So you can't think of, even though the spinal cord is part of the central nervous system, it's, you can't think of it from a perfusion perspective in the same way you think of the brain. Okay, so that's an important concept, I think, to have in mind. The other thing that I've become convinced of over the years is that most injuries in the spinal cord are somehow related to vasculature issues. And by that I mean compressive injuries. The damage really isn't that you're compressing the cord unless it's a huge force, but it's the fact that you're decreasing the blood supply to segmental areas of the cord. And that's, it's a debatable issue. This is something I've become convinced of, seeing hundreds and hundreds and hundreds of cases, that so perfusion is really important in the cord. And so when we see changes, the first thing we discuss with the surgeon is raising the blood pressure to try to get the cord perfused, make sure it's being perfused. And many of the times, the changes will resolve with increased blood pressure. It's not scientific. We haven't done an experiment and posed it as a hypothesis and excluded the hypothesis. But the data we see on a day-to-day basis supports that idea. And I'd be interested to hear what other people that do a lot of spinal cord monitoring think about that kind of thing. So the vascular anatomy is important, and it's important to realize that it's not as divided as we are normally taught. That there is a crossover between the posterior and the anterior vasculature within the cord itself, within the parenchyma of the cord. Dermatomes, we all know about that. The myotomes, again, we know about that. Again, trying to just make the point, you gotta be selective about what muscles you want to record from, because you can drown yourself in recording. And I'm a big advocate of data and a lot of data, but you also have got to be careful that you don't try to acquire so much data that you can't organize it in your mind. Because if you get all these muscle groups, all these muscles innervated by different nerves and cross-innervated by different nerves, pretty soon you'll have so much you're trying to figure out that you can't make a clear distinction for the surgeon, and he needs to know information he can act on, not speculative information about it, maybe this or that or so forth. So we try to do things in a very simple, coherent, consistent way. Same idea. So let me go back to those for a second. For the median nerve potentials, we put stimulating electrodes at the wrist, and we use, again, subdermal needles. For the ulnar nerve potentials, we again put them at the wrist, but we put them on the ulnar side. And again, subdermal needle electrodes. For the lower extremities, we use posterior tibial nerve. We put them right below the lateral medialis. Subdermal needle electrodes again, same thing all the time. And the common perineal, we put one under the head of the fibula and one in the popliteal fossa. Subdermal needle electrodes. So think of subdermal needle electrodes. They work really well, and they'll last for hours. And there's no really risk to the patient. Well, this didn't quite show up the way it shows up. I'm not sure what Can people see that? So this is just to make the point. This is a median nerve response. I like to plot polarities with positive up rather than positive down. So from a traditional EEG world, I'm a heretic, but I lived through the battles of the 60s when the arguments were going on. Made no sense. So the things that we use the most in the scalp, this is a recording from the scalp. It's probably, it doesn't say there, but it's probably C3, P3 to C3, say. Here's N20, P30, and then the later activity. These are 128 stimuli to produce that. You can use two different kinds of stimulus. You can use single phase, which is a pulse going in one direction, or you can use dual phase, which are pulses going bilaterally, symmetrically distributed. There's no reason to use dual phase in particular. Some people like it. We tend to use, again, a 200 microsecond pulse width, and frequencies are adjustable. The amplitude will be adjustable also, so plus A could be anything from 10 milliamps to 50 milliamps, depending on the patient. So the nomenclature is N20, N is down 20 milliseconds after the stimulus, P30, P is up 30 milliseconds after the stimulus. And that's pretty much the nomenclature. It's pretty simple. Yeah, that's what it is.
Short coffee break.
Yeah, this is a good place to start.
Большой кофе брейк, потом продолжим.
Anodal blockage refers to where the anode is. Now, your thought is exactly correct that if you're doing biphasic stimulation, the anode and the cathode reverses. So it's a way of getting rid of anodal blockage. But the other way is just having the cathode proximal. So,
And this is the stimulus for adult potentials, yes?
yes, yeah,
And the second dual phase, it's alternating,
yeah,
yes?
yeah.
And
So you
when
can
we're
do-
using the single phase, it is very important to put the anode more proximal, or
Cathode more proximal.
cathode more proximal.
But in the reality is, I personally have never seen anodal blocking. So I'm not sure how big a problem it is. Now, it could be maybe people use certain stimulus parameters which cause it to occur. Maybe the intensities they use are very high or something like that.
Hmm.
But, yeah, we just never see it. I've never seen it in the reality of it. So, important thing on this slide was just to get the agreement in P30, plus is up, minus is down, simple ideas, and the stimulation. This is a figure that I think is, from the literature, and it's very helpful because it shows you where the different waves are generated at in a very systematic way. This is for the median nerve potentials, so stimulating the median nerve. In the laboratory, people traditionally use a blocking ground on the forearm. We don't do that in the operating room. The idea behind that was to prevent the stimulus artifact. The stimulus artifact's so small anyway that it doesn't make a lot of sense. This is the wave N20 that I was referring to, and then this I was calling P35 on the other one. They call it P22 here. This is thought to come from thalamocortical areas. This is thought to come from primary cortex. This recording was done C3, remember our montage, C3 to FZ. The recording I showed you in the previous figure was done C3, P3 to C3. So we inverted the polarity. So this data is negative up rather than positive up. This is P14, this little wave right here. That comes to the medial meniscus. And that's you record that. This is cervical level 2. So it's from the back of the neck, right below the occiput, referenced again to FZ. So that little wave you see is P14. And then you see, recording from that same site, you can see N13, which is here, which is thought to be the dorsal column nuclei. And then, of course, you get the brachial plexus response, recording one herb's point to the other herb's point. So this is kind of the stereotypic response. The peak-to-peak amplitude of this signal, which is your primary cortical signal, is about 1 to 5 microvolts. It can be as much as 10 microvolts. This response, this peak-to-peak, tends to be about the same as the one here, but the signal we're actually interested in here is fairly small. Could be a fraction of a microvolt. And the same here, these are fractions of a microvolt. And the same here, half a microvolt or less. Time, so you can see 50 milliseconds. All the data I'll show you will be displayed on a 200 millisecond window because it changes the way the data looks. It changes the aspect ratio, called aspect ratio. Same for the posterior tibial nerve SCPs, which are very common. Again, this is stimulating at the posterior tibial, nerve like we talked about, under the lateral malleolus. Again, they've got a ground plate on. We don't use ground plates. I don't know if anybody uses them in the operating room. This is a lumbar response. Another lumbar response. This one's T12 to L2. This response is recorded in the popliteal fossa. And then we've got P40, which is the primary somatic sensory cortex, which they've got labeled here as P37. And then there's this N wave. And these are traditionally recorded from PZ to FC, so right on the midline. I'll show you a little different montage that we use, which actually gives you a better signal. You may also, in these responses, the first thing they're showing here is this P wave. Many times, not all the time, you see a negative wave as the first wave, which is equivalent to the N20 wave in the median nerve response. So it's this thalamocortical complement. So there's actually a real symmetry between the median nerve potentials or the ulnar nerve potentials, they're basically the same, and the posterior tibial nerve potentials and the common peridial nerve potentials. And there are some differences also when we're talking about those. So this is the way we look at the data in the operating room. So this is the system, in this case, the somatosensory system. You have dorsal root ganglion cell come into the posterior columns, project afferently. You've got upper extremity coming in later. So remember we talked about the organization, the somatopic organization of the somatosensory columns that the lower extremities are in the gracilis, come in first, the upper extremities are in the cuneatus, they come in second. Project to the dorsal column nuclei, and then project through the medial meniscus, so it comes up through the brainstem, up to the VPL of the thalamus, to ventroposterior lateralis of the thalamus, and then projects to the cortex according to the somatopic map that we're all familiar with. And this is the way we would look at the data in the operating room. So this is, let me explain this kind of plot because it's a little bit different than what you normally look at. We like to see a lot of data. So we first of all acquire data very rapidly, and then we present a lot of traces. So you can look at this screenshot, and this tells you what we have. In this case, there were a total of 237 epochs of data. So we call a data collection at one point in time an epoch of data. So there were 237 of those acquired successfully from this case. This tells us what the channels are. This channel is C4 to FC. This channel is C3, pardon me, that's P4 to FC, P3 to FC, and then this is cervical level 2 to FZ. So kind of what we talked about in those figures, but not quite the same. And you can see this tracing here is a baseline. The red tracing is the baseline. And the time from here to here is 200 milliseconds. So, but we stimulate every 100 milliseconds. So the way we stimulate, it's interleaved. So in this case, we always do the same thing. We'll stimulate the left median nerve, and we'll stimulate the right median nerve, then we'll stimulate the left tibial nerve, then we'll stimulate the right tibial nerve. So you get 4 stimuli within 400 milliseconds of each other. And this whole thing is going at 2.47 hertz. So every second you're doing this 2.47 times. So if you're going to average 100, say 128 stimuli, it takes you about 48 seconds to get a response. And you've gotten 4 responses in that 48 seconds, all, for all intents and purposes, occurring at the same time, but looking at every part of the spinal column from the somatopic viewpoint. I don't know if that's clear or not. If it isn't clear, I can draw the figure for you. Anyway, so if you look here, you can see the stimulus is applied here at the beginning of the trace. Now you can see, you can't see the stimulus artifact. There's no ground plate on it. You just don't need the ground plate. So then you see this little negative going wave. That's the N20 wave that we talked about picture from the literature. So that's N20, then P30. So you can see, this tells you the time at which these were recorded. This was trace 199, 195. This was trace 207, the way I just put these out on display. So this was recorded at 10:32:26 in the morning. N20, P30, N20, P30 from the other side. So this is the response from the left median nerve. This is the response of the right median nerve. Now, if you look carefully, you can see in this part of the trace a smaller response. This is actually a response on the stimulating left median nerve. These are the electrodes on the right side of the brain. This is a response on the right side of the brain stimulating the right median nerve. So there is, in fact, about 10% of the axons project unilaterally. And so we're actually looking at both the contralateral and the unilateral response when we do it this way. So again, if you look here, this is stimulating the right median nerve. Here's N20 and P30. So then this is this late wave, which is due to association cortex activity. And that's very sensitive to anesthesia. Sometimes you'll see it, sometimes you won't. In this particular patient, we did see it. So important points. What is the amplitude of these signals? The sensitivity here is 5 microvolts per division. So I didn't put the grids on there, the divisions, because it would make the figure very complicated. But you can see these are pretty big responses. They're over 5 microvolts, peak to peak. Now this is the brainstem responses, and you can see the good definition of these things. The P14, the N13 are in there, and you can see the baseline and how reliable this stuff is. So our idea is you want to get the whole thing, and you want to get it fast. You want to get it as quickly as you can, so you can communicate it to the surgeon. In this case, we ran 128 stimuli per epoch, but we've run with as few as 16 stimuli per epoch, depending on the data. So there's no reason to average a bunch of things if you don't have to. Never done less than 16. Okay, so this is the median nerve responses. This now is the posterior tibial nerve responses. And there's a little difference here. First of all, channel 1 is FZ to PC, PZ to FZ. That's what we talked about in the normative data. So recording across the midline like this. Channel 2 is P3 to P4. So we're recording across the brain like this. So P3 is referenced to P4, and then P4 is referenced to P3, depending on which side of the brain you're stimulating. And then we have cervical to FZ and a different cervical electrode to FZ. So you can see how clear these things are. Again, it's 5 microvolts per division, 200 milliseconds. So the idea of stimulate the left side first and then stimulate the right side. So there's a stimulus applied right at the beginning of the trace. Again, you can't see the stimulus artifact. So why put a ground plate on to block the stimulus artifact when it just doesn't occur? And then halfway through is at 100 milliseconds, we stimulate the other side. So this is the response on the midline, this side from stimulating the left side of the cord, this side from stimulating the right side of the cord. So it really makes the cord a unitary object to us, even though we're stimulating left side and right side, and you can see the divisions in the cord. Okay, so it's very sensitive. If something happens on one side of the cord or the other, you immediately see it. You're not trying to figure out what you're doing. Now this response, as I said, this is P3 to P4. So when we're stimulating the left side of the cord, okay, P3 is the left brain. We're stimulating the left side of the cord, the activity is going to be at P4. So this is the left side of the cord, okay, with the activity being referenced from the right brain to the left brain. Okay. When you stimulate at 100 milliseconds, which is in the middle of this thing, that reference switches automatically. It's just part of the way it's set up. So you can get incredibly robust signals that way, and makes it. Those are probably the most robust signals from the lower extremities that we can get. Is that clear? Should I draw a diagram, or are people comfortable with that? Draw a diagram. Okay. So this is at 100 milliseconds. This stimulus is stimulating, we use a nomenclature, median nerve MS, S is for sinister, for the left side, and then MD. That's for the right side. And then we go another 100 milliseconds, and we do PS for posterior tibial left side, posterior tibial right side. So this is again 100 milliseconds. This again is 100 milliseconds. We leave 100 milliseconds for the response, and then we leave some little dead time. We do this at 2.46 hertz, which is about 420, 400, let's say 410 milliseconds. So every 410 milliseconds, we produce a train of stimuli like that. Okay, so, and we allow 100 milliseconds to look at a response. So we get a response. This is the left median response recorded from the right brain. So it's the left spinal cord. Then we get a response, okay, which is left brain to the right response. Then we get something that looks like that, and then something that looks like that. So that's what's shown in those figures. And it allows you very rapidly to map that entire part of the neural axis. Now the other thing though we show is we do this stimulation, we get that, then this guy stimulating here, this is our right brain. There is a response in the right brain from the left brain. This is the left brain response in the right brain electrode. If you get what I'm saying, because we show the issue is the following: we project the afferent information is coming out, crossing over through the medial meniscus. Here's the DCN. And going up to the LPL, the cortex. Okay, that's the path we normally think of. But in fact, this is 90% of the fibers, and 10% of the fibers stay ipsilateral. So we're looking at both sides, and we're looking at both sides at the same time. So it gives you a more complete picture of what's going on in the spinal cord. And so by picking this set of numbers, we can do this very rapidly. 40, turning over a new, for 128 stimuli, it's about 48 seconds per set of responses. So this is heresy. If you go look at the American Academy of Neurology standards, they finally are changing. But for years they said 1 stimuli per second to 1 extremity was their standard, and 1,000 stimuli. So they recommended 10 minutes per extremity to get 1 response. Well, you know, we're doing this sometimes with as low as 16 stimuli. You can imagine if we're stimulating at 2.46 hertz and we're only using 16 stimuli, you're seeing a response every few seconds, every 6 seconds, 7 seconds. So it's a different philosophy, but it gets you at, because the goal is to see as much of the functioning of the spinal cord or whatever part of the brain you're trying to protect as rapidly as possible, keeping it as simple as possible. So there's some complex ideas in here. The stuff's described in the notes, and it's extremely useful. Let me just make a comment about this, because this can confuse